Hello everybody, my name is Stephanie Al-Adhami. I am a master's student at the University of Maryland School of Nursing, studying for the Health Services Leadership and Management Program with a focus in education. And in addition to that, I am also a peri-anesthesia nurse in an ambulatory setting surgery. And what that means is that I work in the pre- and post-op setting, helping folks prepare for their surgeries, recovering them in the PACU or the post-anesthesia care unit, and then preparing them for discharge home from the phase 2 discharge area. And that's why today we're going to be talking about post-op discharge education, specifically strategies to improve retention for our patients. Now, there's a few objectives that we're hoping to get out of this discussion today. First of all, we'd like to discuss how anesthesia itself impacts education retention, as well as the barriers to learning that are present specifically in the perioperative setting. We'll also be talking about some of the benefits of starting surgical discharge process early, the education process early, and the importance of considering different learning styles when educating our patients. So before we go through any of that, it's important for us to consider why, right? I mean, why is any of this important? Well, according to the CDC, back in 2010, there were over 48 million outpatient procedures performed in the United States alone. Now, at the time, that would have equated to one procedure for every 7th person living in the United States. So we can see this is becoming very, very popular for folks to get their outpatient procedures done. Also, as we go across systems, whether it be in an ambulatory surgery setting, in a hospital setting doing surgeries that are same day, we're finding that discharge education is primarily being given post-operatively. And for a number of reasons that we'll touch on, that's not always ideal. And perhaps most important for hospitals considering reimbursement is the implementation of OAS caps. If you've worked in an inpatient setting, you're probably familiar with HCAPs. And this is the new outpatient and ambulatory surgery version of that process. While it's not currently mandatory, the plan is for it to become so, and it will impact reimbursement for these particular settings, making it more important than ever to make sure that our patients receive the best education in the best way possible so that they can get the best experience. Now, before we start going into education itself, I think it's important to review what type of anesthesia are our patients getting. In an outpatient setting, they're usually not getting anything too intensive because they have to be ready to be out the door in a couple hours. But they are receiving generally these 4 categories of medications. Anesthetic agents such as propofol, which help our patients stay asleep during surgery. Perhaps barbiturates such as phenobarbital. Benzodiazepines such as Versed help reduce anxiety prior to procedure, and opioids, of course receiving these during surgery such as fentanyl, helping to prevent any pain folks are feeling during the procedure itself, but maybe also receiving these in the PACU setting as well, in the form of IV Dilaudid or PO oxycodone, something along those lines to help with any acute postoperative pain. Now the thing to remember with these 4 types of medications is they share a couple of side effects which impact how our patients retain education. They can cause memory loss, confusion, and pretty extreme fatigue. Now, if we're educating our patients post-operatively in a setting where they've received any one or most likely combination of these medications, I don't think we're really setting them up for success in retaining what we're telling them. Now, in addition to the barriers of overcoming anesthesia, there's hospital barriers that they need to overcome to retain their education. First of all, communication. And I don't just mean me and you having a conversation with each other. We're talking about language barriers, individuals who don't speak English as a first language. And even for those who do, there can be health literacy barriers as well. That means that they don't necessarily have a good grasp on health language, health concepts. And if we don't try to speak to them at their level, they might not gauge or understand what it is we're telling them. There's also a noise factor, which I think anybody who works in a hospital would tell you is pretty common, and a lack of privacy. Now, while a lot of hospitals are transitioning to single patient rooms, which is fantastic, Surgery, especially recovery, is still often set up in an old ward fashion, where you might have 6 or 10 or 20 beds separated by curtains, where you can hear exactly what's going on next to you. If you have all those distractions and you're worried about your own privacy, you're probably not retaining what people are telling you. Finally, nobody would argue surgery is an emotional experience. Anxiety before you go back for the procedure, fear as you're getting ready to head home and take care of yourself. Can you actually do it? And of course, probably dealing with some pain in there as well. All of these things together impact our education retention. So the question becomes, how can we optimize the retention that our patients are experiencing after we educate them for home? First of all, we must consider timing. So, as we alluded to earlier, most post-op or most discharge education is being given post-operatively. Now, what we talked about with anesthesia and the hospital barriers to learning, that doesn't really seem like an ideal environment. Education should really be beginning on admission, and this is for a couple of reasons. First of all, it's obviously prior to patients receiving their anesthesia, and without having side effects from those medications, they're in a better place mentally to be able to retain what we're telling them. It also gives us a good opportunity for the family of the patient to be present. Now, if you are experiencing emotional distress or concerns about your surgery, it's always better if there's somebody nearby who can be there to listen with you. And finally, if we start early, it gives us the opportunity for repetition. We tell them when they come in the door, when they're going through the preoperative process, we reiterate with the family prior to the going back for the procedure, and then again, perhaps prior to discharge home, we can reiterate what they already know. It's also important for us to consider the learning styles of our patients. Now, research shows us that there are a couple different learning styles that people use, or ways that people best retain information. It might be through written information, visual, auditory, through hearing the information, or kinesthetic, through performing something on their own. Most people don't use just one of these methods to retain what they're taught, but if we're able to help utilize multiple methods at multiple times, we have a higher chance of reaching our patients and helping them really retain what it is we're telling them. So what I wanted to take the opportunity to do now is show you a very brief video clip of what an auditory teaching tool might be that we can show to our patients preoperatively. This is something we use in my own hospital setting, and I think it might be beneficial for you to see here. Now, something else that we need to consider for our patients is communication. As we said earlier, this might be in the form of health literacy or for individuals who don't speak English. Now, health literacy, I love this cartoon because it shows that Mr. O'Donnell is really trying to follow the instructions that he's been given, but it's just not hitting home because it wasn't taught to him in a way that he can understand. How we can help best our patients to understand is developing our education materials at a 6th grade level. Now, even if that's not the highest level of attainment for our patients, it does help them to have a better grasp on what's going on, especially considering the barriers they might be facing in the perioperative setting. In addition, as we alluded to earlier, it's important to avoid jargon. Even if you're a native English speaker, you might not understand the jargon that comes with a certain profession you're not familiar with. Most folks who aren't lawyers might not know what quid pro quo or habeas corpus means unless it's been told to them in a previous setting. And the same goes for our patients with medical care. That's why it's so important to use plain language. Now, if you have patients who don't speak English at all, it's vitally important that we get them the interpreter services that they need. In fact, it's federally mandated that patients who come into the hospital setting must be provided with an interpreter at no cost to them to help them understand their care. Depending on the setting you work in, this might be in the form of an in-person interpreter, over the phone, or through video services. You might have the option of all three. But the important thing is that these individuals are specifically trained for medical interpreting. They're not family members who might, although be bilingual, might face the same jargon and communication issues that we mentioned earlier. So I wanted to take this opportunity to go through a case study with you folks. This is Mrs. Lopez, a 54-year-old Spanish-speaking patient. She does not speak any English at all and is status post-umbilical hernia repair. She's in the phase 2 discharge area. Her son has been brought back to see her. And unfortunately, her discharge instructions were not made available to her in her spoken language. So the son, being bilingual, has offered to interpret for his mother, and the nurse is utilizing him to do so. They state that they understand their instructions and are discharged home without incident. But 3 days later, unfortunately, Mrs. Lopez's son calls the surgery center to say that she's been admitted to the hospital through the emergency department for overdosing on her opioid pain prescriptions. So I'd like you to consider from this case study, what went right? There were some things that went right, and also what went wrong. After you've considered, maybe try to come up with some suggestions for improvement. What could they have done differently in this situation to help prevent that outcome for Mrs. Lopez? In conclusion, post-op education retention or discharge education retention is becoming more important than ever for our patients. The anesthetic side effects from the medications we give patients for surgery certainly impact their ability to retain what we're teaching them, especially if we're only teaching them post-operatively. Those side effects, in addition to the hospital barriers to learning that are introduced in the perioperative setting, do not set us up for an ideal learning environment. That's why it's important to optimize discharge education, that we're considering timing by starting the process early, learning styles of our patients by trying to appeal to different types of learners, and addressing the communication needs of those we're teaching. Thank you very much.